Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. Well, the colonoscopic surveillance of patients with inflammatory bowel disease is a standard practice recommendation, and we recognize the increased risk for colorectal cancer and hence the increased surveillance strategies. Well, the AGA recently provided a best practice recommendation strategy for refining the practice of what we do. And most recently, Dr. Uma Mahaveden, an expert in the field of inflammatory bowel disease, provides her top 10 recommendations, which I think really provides some wonderful granularity to build on the AGA consensus recommendations. Let me highlight her top 10. One is to use a pediatric colonoscope in patients with Crohn's disease. Recognize the outside diameter of the adult colonoscope is 12.8 millimeters, and for a pediatric colonoscope is 9.5 millimeters. These changes in size may make it easier to pass through tight areas, and the flexibility of the pediatric colonoscope may make it easier as well. Second is begin the IBD surveillance 8 to 10 years after the diagnosis, but immediately after the patients have the diagnosis of primary sclerosing cholangitis. Once these patients have been defined and once they've had an adequate exam, patients that have limited disease, so disease that's limited to the rectum, pouchitis or proctitis, or disease that involves less than 1/3 of the colon, the recommendation is these patients could then be advanced to a 5-year interval. And this recommendation also is the same from the AGA consensus recommendation. Third recommendation, if the patient has active inflammation, it is unlikely to be an adequate examination. The reason is that inflammation can be confused with dysplasia. And so Dr. Mahaveden will recommend that these patients be brought back once they're adequately controlled, and she may sometimes use a short burst of steroids to accelerate this control and then bring them back for further evaluation when the disease is in remission. Fourth recommendation, you don't need to take the 4-quadrant 10 centimeter every 10 centimeter biopsies anymore. The advances of endoscopy with the virtual chromoendoscopy that involves either the narrowband imaging, the eye scan from Pentax, or the advanced blue light imaging from Fuji. These are things that will take the place of chromoendoscopy in some circumstances, and you don't need to do the standard quadrant biopsies, random biopsies, if you will. Rather, spend the time more inspecting with the mucosal scrutinization using advanced imaging and high definition colonoscope exam. Again, if you don't have high definition, you need to do the standard recommendation of quadrant biopsies, but high definition is really used by most of us in clinical practice. And next, number 5 is no, every IBD surveillance does not need dye spraying chromoendoscopy. Again, these enhanced imaging techniques I've mentioned certainly are comparable, and even high definition white light endoscopy is comparable. So again, the point here is to be familiar with the best strategies that you know and have the expertise to define dysplasia in these patients and be comfortable with that. But again, the time afforded to identifying lesions rather than blind biopsy certainly makes it easier going forward. Number 6 is do not any longer call lesions DOM. When I was in practice beginning as a gastroenterologist, we had the identification of dysplasia associated like mass lesions, and this was concordant with the next step for surgery, resection of the colon, because it was such a high-risk concern. Or more recently, the modified Paris classification describes the proper nomenclature for dysplastic lesions found in IBD patients. And these are polypoid visible lesions. So polypoid is greater than or equal to 2 millimeters. This can be pedunculated or sessile, or non-polypoid, that is less than 2.5 millimeters tall, or invisible. So these are picked up on random biopsies for dysplasia. And these lesions then warrant careful endoscopic definition and consideration for endoscopic resection. I would also add in these lesions, it would be critically in standard practice recommendation would be to also define the mucosal surface. The recommendation would be to use a Kudo pit pattern, again, as we would for standard polyp resection assessment, and this would determine whether or not these would be endoscopically resectable. Seventh recommendation is do have a second GI pathologist if there's a question of dysplasia. A lot of the times these are overturned as an outside diagnosis confirmed by, reevaluated by an expert pathologist, may make this a non-dysplastic lesion or vice versa. So again, a second pathologist, as we do in other sites in other organs, certainly is a recommendation for standard best practice. Number 8 is, if you don't think you can remove it, it looks like a difficult lesion, don't try. I think this would be the same recommendation for polyps in the colon of any sort, and recognize that, again, biopsies of these areas is also not recommended if you think it's going to be an endoscopic resection, because partial resection by an attempt at polypectomy or even extensive biopsies of the area may tack it down, make it much more difficult for the endoscopic resection following a failed attempt. And a tattoo is recommended, so India Ink is recommended to identify these clearly. Number 1, define it where it is in the endoscopic report. 2 is place this at least 3 to 5 centimeters distal to the area. Do not place it adjacent, because this infiltration of the India Ink may tack down the polyp and make it less amenable to an endoscopic resection. Number 9 is, when performing postoperative surveillance for colonoscopic Crohn's disease, make sure you intubate the ileum and use the appropriate scoring system. The recommendation here is to use the Root-Gart's scoring system, and in particular, the identification of just the blind pouch. So if you go by the anastomosis, may miss, in fact, disease in the ileum, which again would be reflective of inadequate therapy. And the Root-Gart's scoring system is something you should use in standard definitions. This is a 4-tiered scoring system going from I0 to I4. There is a subset of I2, A, and B, predicate on aphthoid ulcerations in the ileum and or disease limited to the anastomosis. Would be an I2A, and I2A to 0 would reflect generally good medical management and not need a medical change, and I2B to I4 would reflect disease, high likelihood for disease progression and recurrent surgery. So again, medical management strategy would need to be addressed. And the final recommendation is to perform annual surveillance of the ileal anal pouch in high-risk patients. These are patients that are certainly the high-risk pouch patients, would be previous history of dysplasia, colon cancer, or primary sclerosing cholangitis, or chronic pouchitis, and these should be annualized. Again, the recommendation here is to do a retroflex in the pouch, and make sure you also do biopsies of the pouch. So the pouch should be biopsied proximally and distally. Dr. Manavadan's recommendation is 2 biopsies proximal and distal, as she puts them in the same jar. I think that's fine. But also an excellent recommendation to give a puff of air on the way out, just to make sure that you, as you exit, you see the anal verge and the ileal anal anastomosis, again, areas where cancer can be indolent and certainly is defined in these patients, an important recommendation to visualize these. So top 10 recommendations, I think, really provide excellent granularity. I think the points are: make sure we use standard language, we use the most appropriate definitions that we can, and we use the most appropriate high technologies that we can to identify dysplasia. It needs to be done by people that are familiar with these technologies, familiar with the nomenclature, and also then we're familiar either with the appropriate endoscopic resection, or at least recognizing when these patients should be referred to an expert center that is capable of doing these things. So hopefully this discussion amplifies what you're currently doing, or exemplifies what we should be doing to be the best practice strategies in our patients, surveying them with inflammatory bowel disease. I'm Dr. David Johnson. Thanks again for listening.